good evening, everyone, and thank you for inviting me on this platform. And special thanks to Dr. Mawela as well, who's been, I think, behind the scenes trying to make everything work. And I hope in the next 45 minutes it will be interactive and we can ask as many questions. But I'll just present quickly the slides that I prepared. I've used these slides in a couple of sessions here in South Africa, I think in Mpumalanga, and also the trainings that we've been doing with the Provincial Department of Health. So I just thought, yeah, it's an important topic, especially with the COVID and all the oxygen requirements that we've come across. And I hope I'm going to answer some of the questions that have been posed already. And I think we're going to have an interactive session as we go through. So yeah, my name is John Masina, and I'm part of the WHO team for the COVID-19 response in South Africa. I was part of the team from August last year. I think we can go to the next slide. I'll fashion my slide in such a way that I'll give a few declarations just for the sake of interest, and then I will give an outline to the law of oxygen therapy and management of COVID, just a brief pathophysiology, evidence around oxygen, and then the global oxygen need, and then I'll describe the different modes of oxygen delivery system. I'll spend a little bit time on equipments, mode of oxygen delivery at different levels of care, and then I'll also talk about the infrastructure challenges, as you know, and the policy guidance. And then I'll also try to elaborate oxygen escalation and de-escalation protocols. And I think that's where we'll spend a bit of some time, and just the red flags and pressure differences and stuff like that. We can go to the next slide. I just want to declare that the information being shared in this presentation are evidence-based, and some of them are personal experiences. As you know, there is no one who is an expert in COVID. It's been new, and most of the information that we have is just from subject experts in terms of emergency physicians, ICU, physicians in general, and everyone else. So a lot of things might be opinions and might be just experience, but I think everyone, we are all learning from each other, and it's good to just keep an open mind about it. Next slide. Cool. So I'll give a brief pathophysiology. I think I would just like to bring to the attention that we know that COVID is a multi-systemic effect. It has a multi-systemic effect, and mostly some of the effects that we've been seeing highly related are the ones that are affecting the respiratory system. And this is just a diagrammatic representation of the whole scenario of COVID and how it affects the respiratory system. If you go there, there's a drawing of an alveoli with the effects that COVID has on it. It causes the tumor necrosis factor, also the interleukin-6, interleukin-4, interleukin-1 activation, that leads to increased permeability in the vessels, increased basement membrane separation, and also just leads to hypoxia. That hypoxia is the one that leads to hypoxemia, sepsis, septic shock, and multi-organ infection, and also death. And I think that's where most of the COVID pathophysiology really lies. But we all know that COVID can also affect the immunopathogenesis, where we've seen increase in the D dimers, increase in coagulability, and also just causing of pulmonary embolism, leading to ventilation perfusion mismatches, and all the effects that it comes with. But I think for today, we'll really just dwell so much on the respiratory system. And then I think we can organize some other webinars where we can talk about the immunological effects. We can talk about the sepsis and the septic shock. We can talk about other effects, like the effects on the brain and the effects on all the other systems, like the kidney injury in terms of chronic kidney injury or renal failure. But today, I think let's focus our attention strictly to respiratory system and how we can deliver oxygen. But that's just a brief outline in terms of the pathophysiology. Next slide, please. So I wanted to pause a little bit, and I think Dr. Mawela is going to run a small polling session where our participants can participate. We just want to see how well maybe we might go into this. But I just want you to take a few seconds, maybe 30 seconds of your time, and just state whether this statement is true or false. Effective oxygen delivery system should be a universal standard of care and should be made widely available. Is this true or false? So we have the poll. I think you all have the poll questions there. We can take, I think I'll take the next 20 seconds just to give you a chance if you can submit your answers by just clicking and then submitting the answers. And then we can have a consolidated poll, and then Dr. Mawela, I think, will give us. So maybe just 20 seconds from now, and then Dr. Mawela maybe can give us the outcomes of the poll. Okay, we still have 10 seconds. All right, so I think we can close the pause. Great. Okay, cool. And we do have the polling system that looks good. 94% of us thinks that it's true. And then the other 6% of us think that this statement is false. We can go back to the presentation. Next slide on the presentation, Dr. Mawela. Yeah, cool. So effective oxygen delivery system should be a universal standard of care and should be made widely available. This was said by WHO in 2016, and this is true. You understand that we've seen a lot of oxygen systems that have been failing, and a lot of oxygen consumption and oxygen demand that has increased exponentially in the last 1.5 years now. And this has become to light, and it's COVID that has really just shown us that we really needed to have worked on our oxygen systems a long time ago, and we really needed to have upgraded. We can go to the next slide, Dr. Mawela. So COVID-19 has really caused way over 4 million, and I think this is over 4.7 million deaths around the world now. These statistics are a little bit old. And yes, over 70% of all hospitalized patients are needing oxygen therapy, with about 20 to 40% of these hospitalized requiring huge amounts of oxygen, and not just the huge amount of oxygen, but the high flow oxygen requirements. And I think this is what has made oxygen delivery to COVID patients really, really challenging. And it's important to have the knowledge of oxygen delivery equipment and their use, and also not just the equipment and their use, but also the management and the monitoring of this oxygen supplies is really vital, is a vital aspect in the management of this pandemic. And we've seen a lot of money being pumped in by the government to try and see that the oxygen modalities have been scaled up at each and every hospital. We've seen at the National Department of Health, we do have what we call the facility readiness workstream, which has really worked tirelessly around the country to install oxygen delivery in terms of man forwards and bulk tanks and Afro. All the other cooperating partners have been coming through to come and give help and readiness in terms of oxygen delivery. And if you think about it, I think we're over 50% of COVID response just circles around how we manage our oxygen. And we've seen a lot of mortalities coming through if we don't manage these oxygen modalities. And that's why we just want to spend time today and just talk about these oxygen modalities. Next slide, please. Here, I just wanted to highlight a few studies that have really shown that yes, oxygen is a vital component when it comes to management of COVID. There was a study in the USA, actually here in South Africa, that showed that oxygen therapy lifts chances of survival in severe COVID patients. And this is true. And I think this study was done in Cape Town. There was another study from the, I think, pulmonology, clinical medicine, which talked about the utilization of high-flow nasal cannula for severe COVID-19 pneumonia in resource-constrained settings, a multi-center prospective observational study. This was done, I think, in the USA. And then I've also just highlighted the COVID-19 technical specifications for procurement of oxygen therapy and monitoring devices right there on the top left. And this is just to bring out that we really need to think about these oxygen modalities, and we really need to think about how we are going to do this. And all the stakeholders, I think, are on board trying to see if this oxygen can be delivered to patients safely and effectively. And we really need to take time to understand these modalities and just try to see how well we implement them in our settings, be it resource settings, and also being at limited resource or even high income countries in terms of ICU and all these tertiary hospitals. But it all starts with us at the district level all the way high up. So if we understand how we give oxygen, that becomes a vital aspect of the management of these patients. Next slide. Here, I just wanted to depict the amount of oxygen that has been used so far and how just the requirement has really exponentially gone up. Look at India. India needed over 13 million metric tons or cubic meters per day of oxygen. And that's a daily oxygen need for COVID-19 patients. And this was at the peak of their pandemic. You remember in April, May, where they used to have over 400,000 patients a day. And then Brazil and Argentina as well, falling within the ranges of 1 to 3 million cubic meters per day. And then the left side, on the right side, on the oxygen cylinders, I was just trying to put a comic to say, I think we should just relabel all the cylinders and label them oxygen, and maybe that would shorten back the oxygen shortages. But look, I mean, now we have labeled all these gases that they are oxygen. We just need to rename them, and then we have oxygen. But I think it's not as simple as that. Okay, next slide. Okay, here I just wanted to give us a few of what systems do we have. And this is, I think, very important. We need to understand our own local context. What do we have and how can we use it effectively? Remember, we do have the nasoprawns, which is labeled number 1 there. And we do have the oxygen from the wall, which is labeled number 2 there, be it from the bulk tank or be it from the manifold. And then also we have the oxygen cylinders, which is number 3 there, together with the flow meters and all the regulators there. And then we do have number 4, we have the oxygen concentrators. These have, I think, have become very, very, very important because everyone is now knowing about oxygen concentrators and how to use them, and the issues of domiciliary oxygen are coming in. And then we do have the Venturi masks, which are labeled number 5. And then we do have the non-rebreather mask or the poly masks, which are labeled number 3. So what is important here is that we need to understand what we have. We need to understand how to reorder them, and we need to understand how to use them. Very, very vital and very important. We can go to the next slide. Here, I just wanted to show some of the other higher levels of oxygen provision, like the CPAP. There, it's a CPAP mask. And also on the left side, it's a high flow nasal cannula. Different modes and different setups, but they all have the same principles of being used. And then on the bottom left there is a ventilator with all its connections. And I think that should be a Philips ventilator, which you can use either as an invasive ventilation, or you can use it as a non-invasive ventilation using the BiPAPs and the CPAP modalities. But we'll talk about those, I think, as we go in the presentation. Then I wanted to take a slight pause on the next slide. We can try to think about this and then just talk about it, and then we can do the polling as usual. Clinical signs are not a reliable indicator of hypoxemia, true or false. We can take 30 seconds. Okay. So yeah, just think about it. What do you think? Are there Are the clinical signs a reliable indicator of hypoxemia? And what's your feeling? Can you objectively assess the hypoxic levels of a patient just by using clinical signs? I think I'll give it the next 10 seconds, Dr. Mawela, and then we can continue. All right. So it shows that 49% of us think that clinical signs, yes, they are not reliable. And then about 53% of us are thinking that clinical signs are actually reliable. Because if you say true to this statement, it means you are saying they are reliable. If it says this statement is true because you are agreeing to this statement. If you say false, it means you are refusing that this statement is wrong. So next slide. So I just want to bring to attention of the audience that in COVID, I think we've learned a lot. And one of the factors that we've learned in COVID is that clinical signs are not a reliable indicator of hypoxemia. So the ones that answered true were actually correct in the previous poll, but I'll come and give the answers at the end of it. But what I want to bring is the vital aspect that the pulse oximeter has played in this pandemic. We have seen a lot of patients with the GCS of 1515, hemodynamically stable, everything looks fine. You put a pulse oximeter on them, they've got saturations of 70, 60, even as low as 40, but the patient is still talking to you. So we really need to invest in the pulse oximeters, different types of pulse oximeters. I think on the right side, I've also tried to add a blood gas analyzer because this has become very, very important. We are not going to assess these patients without these gadgets. And this is very vital because most of these patients have got very good vitals, but when you do the pulse oximeter, you find that they've got a low saturation, that they need oxygen, but they don't show it clinically. And by the time they start showing it clinically, then it's too late. So us as clinicians, we need to be wary and know that clinical signs are really not a reliable indicator when it comes to COVID. This is the only thing that I think it's the most important thing that we've learned from COVID from the start of the pandemic. Next slide. And I've just tried to highlight it there. To say pulse oximeters should be available in all settings caring for patients with a severe acute respiratory illness and used to measure the pulse, the saturations. We need to have them in the pre-hospital, in the emergency area, in the wards, and in the ICU. So blood gas analyzers should be available as well in ICU. Yes, it could be a good modality to have, but it's not a trend smash. I think what is important is that we need to have these pulse oximeters in the pre-hospital emergency area, wards, and all the areas where we are caring for COVID-19 patients because clinical signs are not a reliable indicator of hypoxemia. They might look too good when they're actually very sick. Sometimes they look very sick when they're actually relatively better. So we need to invest in these pulse oximeters and we need to make sure that they are there so that we objectively assess our patients properly, not just relying on the clinical signs. Next slide. However, I want to highlight that clinical signs are important, much as they are not a reliable indicator of hypoxemia, but they are important in the evaluation of the patient. So you need to look at the work of breathing, the use of accessory muscle, the respiratory rate, the vitals, the blood pressure, temperature, and saturations, and mostly of importance is the Glasgow Coma Scale. Any alteration in the mental state is a sign of severe disease. Any patient that comes in confused, even if their SATs are normal and they are COVID positive, they've got a sign of severe disease. So these clinical signs should be used to guide in the treatment of patients, but not in the objective assessment because they are not really reliable. But they should give us at least a vital and very important in the alternative diagnosis. A patient with a pneumothorax, patient with asthma, exacerbation, COPD, who come in with acute respiratory failure and everything, that could be a differential diagnosis if you examine the patient properly. But in COVID, it should not, the clinical signs should not be relied upon if you want to objectively assess hypoxemia in patients. Next slide. So I just wanted to also, maybe this answers the question that was posed at the start of the webinar. When should you give supplementary oxygen? A lot of people have asked this question, and I'm happy that it has come out even before I presented. The best answer to this is that it depends. It depends on the patient. I always tell people that numbers have been devoured when it comes to COVID. Someone can have SATs of 94, but the work of breathing, the respiratory distress, the alteration in mental status should make you start oxygen. So in a hospital setting, give oxygen immediately to patients, adults and children with severe acute respiratory illness who have signs of severe illness. And these signs of severe illness include severe respiratory distress, sepsis with hypoperfusion or shock, altered mental status, or hypoxemia. They might look okay. The numbers can be above 94, can be above 96, but if their work of breathing is high, their respiratory rate is above 25, use of accessory muscles, you need to start them on oxygen. So the numbers are good, but don't rely on them. It's a clinical assessment of the patient that is very, very important. And in pregnant women, we try to go even a little bit higher in terms of the targets where we start where we start the oxygenation. Next slide, please. Okay, so in children, clinical signs that should trigger oxygen therapy include central cyanosis, nasopharynx. Remember, in children, it's very, very difficult for you to objectively assess the hypoxemia, especially that you don't have the equipment. Sorry, I'm just getting a little bit distracted, but yeah, I think I'm back on. So what I was trying to say is that in children, you really need to use the clinical acumen. That is what is very important. Certain conditions will require you to examine the patient fully because it's difficult for you to get the appropriate equipment and appropriate pulse oximeters for you to assess objectively. So look for the clinical signs, head bobbing, and also just lower chest indrawing, respiratory rate above 70. You need to start your oxygen therapy in these children. Okay, let's slow down a little bit and go to the poll question again. Which one of the following gives the correct escalation therapy for oxygen delivery? Is it A, is it B, is it C, or is it D? I'll give the next 30 seconds for the participants to just do the polling, and then let's see how we do on this question. It's one of my favorite questions. Dr. Mawela. Okay, great. Okay, I'll give the next 15 seconds just to see who's pouring and how we are doing. All right. Okay, great. So we have a fair representation. I think 11% of us thinks A is correct, 35% thinks B, 13% thinks C is fine, and then about 43% thinks it's D. A fair representation of all the possible questions. But yeah, we just need to ask ourselves. But let's go into it. So the next slide. I think what we need to understand is that we need to know how we are going to move from one oxygen modality to the next oxygen modality. And for us to do that, we need to understand that oxygen is a drug, it has a dosage, and it has a duration on how we should give it. And then it should also come into play that we have limited modalities when it comes to oxygen, depending on where we are. So I tried to divide our facilities into primary health care or district level, and then provincial hospitals or tertiary hospitals. I think what is important for me is that we need to understand from the background that nasal cannulas, simple masks, and polymasks can be used at the district level. And every time you are moving from one modality to the next modality, you need to understand what you are looking for. Remember, when you're using the nasal prawns, which are the ones on the first box, the dosage is between 1 liter to 5 liters per minute, and it delivers the oxygen of 0.25 to 0.4 FiO2 percentage. That's a nasal cannula. If the patient is not improving, then you move on to the simple mask. So you increase your flow from 6 to 10 liters per minute. It delivers a FiO2 of 0.4 to 0.6, and that's the maximum. Every time you go above the specification, you are either wasting your oxygen or you're harming the patient, especially when you're on nasal prawns. If you increase beyond 5, you're just causing mucosal ulceration, and you are causing distress in the patient, and the patient won't be comfortable. So stick to the prescribed oxygen delivery for whichever instrument that you are using. If you're using a polymask or a non-rebreather mask, it's between 10 and 15, and it delivers the FiO2 of 0.6 to 0.9. And that's the specification. If you go beyond, it will just be wasting your oxygen and making the patient uncomfortable. So we really need to understand this, and we really need to understand the dosages as well. At the provincial level and tertiary hospital, maybe you can think of modalities that you can do, like double oxygen. I think we've heard about double oxygen, where we combine a non-rebreather mask together with the nasal prawns. That's where I've put NP. And then when you go to high flow modalities, you can think about the high flow nasal cannula. You can think about the C-circuit. You can also think about the Oxera mask. I think some of us in the audience, we might have had the experiences with an Oxera mask. This is a mask that is being used in Eastern Cape, and it's doing very, very well. And we are hoping that it might be commercialized to other provinces as well. But I think we need to start thinking about it. It's just a non-rebreather mask with an addition of a PEEP to it. I think it goes to up to a PEEP of like 5 or 20 maximum. And then we have the NIV, which is now the CPAP mask and the BiPAPs. So, and then later on, we might start thinking about ventilation. So I think the modality is that it should start with nasal prawns, then it goes to simple face mask, then from there it goes to non-rebreather mask, then from the non-rebreather mask, it goes to high flow nasal cannula, and then it goes to CPAP. I think the option number D was the correct answer on the previous poll. So that's how we go in terms of the oxygen escalation. But I think, okay, sorry. There will be a bit of questions as we go on, but I think we'll elaborate more when we come to questions. Next slide. Here, I just wanted to show how do we titrate the oxygen. Okay, so we want to target the oxygen in such a way that you are targeting your saturations. And remember, I talked about the saturations, and I talked about the numbers, and I talked about the indication of starting oxygen. What is important again here is the patient. It's not the number, it's the patient. If the patient starts above 90 and they are comfortable, they are breathing okay, they are not using accessory muscles, they are not labored breathing, you can try to keep them on that modality. But if the work of breathing, if the confusion is coming in, if the cyanosis and everything is coming in, even with SATs of 94 and everything, you need to increase the oxygen target. So what is important here is that you need to titrate oxygen up and down to achieve the targets. But the targets should not just be numbers. It should be the patient. It should be an objective assessment of the patient as a total patient. Work of breathing, saturations, GCS, and also just the comfortability of the patient. And always don't wean off oxygen when the patient is unstable. Always only wean off oxygen when the patient is stable. And by stable, I mean all the parameters that you are looking for are within the normal ranges, the respiratory rates, the heart rate, the blood pressure, the mentality of the patient. That is what is important. Next slide. Here, it's quite a small slide, but I think Dr. Mawela, I think, is going to share the presentation. We just need to uh, find our own way of coming up with a protocol of how we are going to administer this oxygen to patient. And I was trying to come up with a simple protocol that we can teach everyone as an initial oxygen therapy at all levels of care. So I've put patient presentation, and then I've put parameters there. 1, patient with saturation less than 90. 2, increased rate of breathing, respiratory rate above 30. Neurologically stable, GCS 15-15, hemodynamically stable, BP pulse, and normal or within normal ranges. And then 5, suspected or confirmed COVID. If the saturation is less than 85, you start them on a non-rebreather with a reservoir bag, which is a polymask, and you open it to 15 liters per minute. If their saturations are between 85 and 90, you start them on a simple face mask, and you open it at 10 liters per minute. If their saturations are above 90, but they've got increased work of breathing, remember in the first box, then you start them on a nasal prongs or nasal cannula at 5 liters per minute. Until they are, then you can recheck the patient and reassess them and titrate up and down depending on their response. If you go, you can read on the small footnotes that I've put there. They're just trying to guide you how you are going to escalate or de-escalate the oxygen depending on the response and the improvement of the patient. So yeah, next slide. Okay, so on this slide, I just wanted to give the infrastructural challenges, and I think all of us here understand because we are coming from different facilities, and these things are pretty much standard, and we'll always have them because it's very difficult for us to have new hospitals with everything that we want. Space is one of them. There is limitation in space. Overcrowding is a challenge in the emergency department. Exit block, patients are spending so much time in the emergency department, we end up being an extension of an ICU. Access to space, triage system, physical distancing, and hand washing has always been a problem. And also health facility design, not suitable to handle infectious diseases of this nature. And also just portable oxygen is a problem, and also portable equipment for diagnosis and treatment like X-rays, CT scans. These have all been a real challenge, and they've put a lot of challenges on how we handle these patients. But I think what is important is that all facilities should have a designated screening area, updated screening and risk assessment tools which are locally formulated, and I think we do have them in the National Department of Health guidelines. All facilities should have some form of isolation, a room or a ward for suspected and confirmed cases with strict adherence to infection prevention and control measures. All healthcare workers to adhere to IPC measures and protect themselves at all times. This is very, very important. And then all facilities should plan for oxygen delivery equipment and formulation of a localized monitoring capacity for both consumables and PPE. It can never go without the emphasis. And then you have to plan for reorder levels. You also have to understand individual facility limitations like space and ICU. No ICU, it means you have to refer patients early. And then timely and well-coordinated referrals. This is one of the most important. Risk identification, treatment initiation at the lowest level of care, enough portable oxygen when you are moving the patient, and adequate communication to the receiving facility. I think this cannot go without emphasis. And we should always plan our referrals. It's either we refer the patient early or we keep the patient until we intubate the patient. Those are the only two options. And every time we are moving the patient, we need to understand how are we going to move the patient and how is the patient going to reach the other facility? Have we communicated? Are they ready for this patient? We've seen a lot of intra-facility mortalities when it comes to COVID. It's because of the oxygen management in the interim of movement. All right, Dr. Mawela, I think let's try to pause up a little bit again and think. This is also another one of my good questions. In the treatment of COVID-19 patients on oxygen, which of the following will you consider changing as you escalate the oxygen therapy? A, are you going to consider the flow of oxygen? B, are you going to consider the FiO2, which is the partial pressure of oxygen in inspired air? Or are you going to consider changing the pressure, which is the PEEP and or the pressure support? Or you're going to change all of the above. All right, I'll give it 20 seconds for this one because it's too good. And then we'll see how we are going to pour on this one. Okay, I think 20 seconds starting now. Right, so we just need, the emphasis here is just us to think through and see, if I move from one modality to the next modality, what is it that I want to achieve? And that is what is important. Okay, I think we are 20 minutes. Let's see how we performed. Great. So 13% of us think we can change the flow, and then 6% think we can only change the FiO2. The other percentage think we should change the pressure, and then about 75% of us think we should change all of the above. Okay, cool. Let's go to the presentation and then move. Great. So this has been one of the biggest things that I think we've learned also in COVID, is that every time you are giving oxygen to these patients in COVID, you have to think about it. You have to think, will I change all the 3 parameters of oxygen, the flow, the FiO2, and the pressure? The change in flow, the change in FiO2, and the change in pressure at a later stage of their treatment should be considered way early. So we should always ask ourselves, what are we changing when considering escalating the delivery of oxygen? Let's say the patient is on nasoprons and you want to move them to simple mask. You've already changed the FiO2. Remember, the nasoprons go from 0.25 to 0.4. The simple mask goes from 0.4 to 0.6. So you've already changed the FiO2 and you've changed the flow. Remember, the nasal cannula are going from 1 to 5, but when you go to a simple mask, you're moving from 6 to 10. Early identification of patients and early treatment is the key. And this has to be done so that you change. So the patient needs to have an elaborate treatment plan. And on the left side here, I've tried to give one abstract that I think I got from also from the pulmonology guys. This was, I think, published in January 2021, on the 20th of January 2021. They talked about non-invasive respiratory support parts in hospitalized patients with COVID-19. They proposed an algorithm. We should also have this algorithm with us at our hospital, our own algorithm that works for us, that is fitting into what we have, into the equipments that we have, and into the skills of level that we have. And that's what is important, our own, not what they are using at Charlotte McKessie or what they are using at Steve Biko, but our very own, something that is within, which is us, within our reach. And that's what is important. Every facility should have an elaborate oxygen escalation plan. When we move from here, we are going to move from here, and then from here, we're going to move from here. Depending on our skill, if we reach here, the patient is not improving, we need to transfer, and that's what is important. Next slide. Okay, great. So I also wanted to pause a little bit because I think I'll come and do the last bit of it in the next 5 minutes or so, but let's just think about it. Which of the following is a clear indication of de-escalation of oxygen therapy in a COVID-19 patient? A, is it the improvement in the Glasgow-Coma scale? Or B, the reduction in the respiratory rate and the work of breathing? Or C, the improvement in the saturations and hemodynamic status of the patient? Or D, the reduction in the D dimers? And then E, it's A, B, and C above. What do you think? All right, let's give it 15 seconds. And then we can see how we have performed. So far, there's been a very good voter turnout. And we're having very good percentages. And I think as we go, we are trying to see how things are just unfolding from one place to the next. Okay, Dr. Mawel, I think you can give us the results. Okay, great. So A percentage of us, 1%, thinks we can just de-escalate depending on the improvement in the GCS. 3% of us think reduction in the respiratory rate and work of breathing is the only thing you can go with. And then 20% of us thinks improvement in the saturation and hemodynamic status of a patient is a good thing to go with. And then none of us thought reduction in the D dimers, which I'm happy. And then 76% of us thought A, B, C, and D is the correct answer. Let's see. We can go back to the presentation for the last bit of it. De-escalation method. So it is never a one-size-fits-all. The most important thing we should know is that we should know our patients. Be mindful of the psychological effects on some of these patients, and also the principles of COVID-19 is give time to recover. Patients will need a bit of some time. And every time you want to de-escalate the patient, always think about the post-acute sequelae of COVID. These patients are staying on oxygen for a longer period of time. And sometimes they develop this psychological effect, and sometimes they just develop this fear that once I move out of this oxygen, I'll die. So they will stay on that oxygen for a longer period of time. But I think what is important is you should know your patient. You should know your patient, and you should scale them down according to what you want. Look for improvement in the parameters like the work of breathing, the respiratory rate, the SATs, the Glasgow Coma Scale, the hemodynamics, and of course the labs. But the labs should not be the one to determine whether you are going to de-escalate oxygen or not. Because remember, there is always a delay in the improvement in the lab. Sometimes the radiological effects can actually get worse. From day 1 to day 5, you find that the chest X-ray is getting bad, or even the CT scan is getting bad. But for you to start de-escalation, the most important is to consider everything together. And that's when you make a decision for you to start de-escalation. As a guideline, you can start by reducing the pressure, then followed by reducing the flow, and then lastly, you can reduce the FiO2. But I've put a star there to say a combination of reducing pressure and FiO2 simultaneously is acceptable, and careful titration is needed, and this should be done by a senior personnel. Always in consultation with the ICU guys, always in consultation with the physicians, and always in consultation with the specialist. And I think what is important is also that it depends on where your patient is. If the patient is in ICU and intubated, my first priority is to win down the FiO2, because I want the lowest FiO2 as possible to give me the best stats that I can get. And then later on, I can play around with the pressure and I can play around with the flow. If the patient is in the emergency department, or they are not ventilated, they are not intubated, they are mechanically ventilated in terms of NIV, the best is to start reducing the pressure so that you can mimic the polymask or the non-rebreather kind of conditions, where you have a high FiO2 and you have a high flow, but you don't have any pressure. Then once you can win off the pressure, you can convert them from non-invasive to a polymask or to a high flow nasal cannula. But remember, patients that are on NIV cannot go straight to a polymask because they need that pressure. They will probably crash if you do that. So you need to create an environment as if they are on a polymask, and that's when you go down. And then I've just put a comic there to say he was doing very well at first, but then he started drifting in and out of health coverage. I don't know what that health coverage is. All right, next slide, Dr. Mawe. Great, I think we should be finishing in the next 2-3 minutes. Okay, here I just wanted to give a little bit of a guideline when it comes to refer and how to refer. And I think this is very important. And I think everyone should come on board and look at this. Increased work of breathing, use of accessory muscles, and deep, slow breathing, which is gasping, should be a clinical red flag. A heart rate above 120 is a clinical red flag. Respiratory rate above 30 is a clinical red flag. Altered mental status, I think we've talked about. Elevated initial blood sugars is a predictor of mortality and a predictor of poor outcome. Presence of any comorbidity is also another issue. So every time we're thinking about a patient, these are the things that we should look out for. Does this patient have any clinical red flags that I shouldn't refer them? The other thing is I've put laboratory and radiology in small letters because they are important, but they should not make a decision. The decision should be based on clinical, high D dimers, chest X-ray with massive infiltration, leukocytosis and lymphopenia, and elevated CRP, ERS, and PCT are very, very important. These are also clinical red flags. A patient can be doing very well, but he's got a raised D dimer. You are worried about them. You need to keep them. Give them a bit of anticoagulation, but that should not be, because remember, these labs and radiology, they take long. You need to make a decision based on clinical. And this determines whether this patient goes home, stays in the hospital, or goes to a higher level of care. And then how to refer a patient is also very important. At primary healthcare level, maximum level of oxygen is non-rebreather mask. If you go beyond the non-rebreather mask, you need to start thinking about either I should refer this patient or I should ask for specialist involvement. Patient needs a scored risk according to red flags. We need to have this scoring system that you need to keep. And it's very, very important because this is what determines how you're going to treat the patient. Treatment has to be initiated, especially oxygen and sugar control has to be initiated even as you transfer the patient because it has a good outcome. The earlier you start your oxygen, the better. Remember, oxygen is both therapeutic and prophylactic. It might delay the patient going into severe disease, and always pre-arranged referrals with proper prior communication to the receiving center with numbers of referring doctors and receiving doctors given to ambulance crew is a must. Make sure there's enough oxygen before you start off, and make sure you have a backup system when you are transferring the patient. And this backup system should be in terms of oxygen, drugs, and personnel. Okay, make sure you have enough oxygen to drive you going there and coming back so that in case of any delay along the way, the oxygen will still cover you. And also you have phoned someone so that you have a backup in terms of transferring this patient. Next slide. The next slide, I just want to thank everyone and just encourage everyone that please consider being vaccinated. The safest and most effective vaccine is the one that gets into your arm first. Regardless of what the vaccine is, go for vaccination. Thank you so much for your attention. Feel free to ask questions. I'll hand over back to the chair for the session. Thank you so much. Thank you.
Wow, great. Thank you. Thank you so much, Dr. John Masina. This was very wonderful presentation, very informative, very educational, you know. At some point I felt like, wow, maybe I should quit ENT and just work in the COVID ward. Maybe I could save many, you know. And it's through this kind of webinars and presentations that we learn so much. Most of the worrying questions have been answered. If not all, some of the questions that I've posted prior to your presentation have been answered. In the chat box, people say this is a wonderful presentation. They hardly even have questions. Your poll questions, quite interesting. I wonder how Dr. Mawela answered. But nonetheless, we're running behind schedule. The meeting is supposed to be done. I'll just plea with the audience for the next 5 to 10 minutes so that we can be able to take any comments or questions. But before we take any comments or questions, I'll ask Dr. Mawela to come back. We all agree that this informative presentation, and of course it's through this good clinical care platform that we have learned so much today. So I just want Dr. Mawela to clarify for us a few things. How do I become a member of the clinical care platform? How do I get other topics that I've missed? And how do I plan forward in getting into new topics that will be coming in just 2 minutes before we go to Q&As. Dr. Mawela, quickly, please. Dr. Mawela, you need to unmute your mic.
Dr. Sukole, thank you very much for that. Just to say that, thank you very much for joining, colleagues. Firstly, we have a clinical care platform. It's no longer just about, the webinars. It's now a digital platform which you can visit. You just type in www.clinicalcareplatform.com. You will get, to this page. And you can see it says leading the way in high quality continuing professional development. So ours is to, really create a lot of content for you, educational materials that you can consume. The platform is able to help us to register you for the live virtual workshops, similar to this live webinar, but also some of the live workshops that we will be hosting. We also have some of the short lessons, like this 1 hour session. If you want to come and watch it, you would come back to this particular section. It also allows us to do e-learning programs, dispensing, and many other clinical programs that you might be interested in. Public workshops, face-to-face, so you'll come there and see, what's coming. And then all the learning really is done online, because we really want to improve, the convenience and for you to be able to study and reflect, wherever you might find yourself. If you look at the live webinar session, which is where most of you registered, you would see that there is a live webinar session. There's also a dispensing live workshop, which is going to come through. We've got the series of e-learning, sessions like your pre-exposure prophylaxis in HIV negative people as part of prevention. The course is described nicely for you. We don't have any upcoming events, as in public face-to-face, but there are some live webinars that you can get there. Also, if you are an institution and you are interested to train your staff, you can make an inquiry. The last bit is to say, then how do you contact, the platform when you need help? There is a number that you can use. There's also an email which you can type in and then send us whatever information you need, and we will be able to help you. The last part is to say, now that you have attended this webinar, how do you get your certificate, right? Most of you must have noticed that when you were required to register, the system said create a password. This is because of this, right? The icon there on the right upper part there. So you have to log in. Like now I'm going to log in. It says I must put in my email and password. I'm going to do exactly that. And then I'm going to log in, you see. So if you had any courses that you were registered for, they would be listed here. And then if you complete any course, like now, corona disease, I've already completed this course, as you can see. Joe Bergman, so Gole was saying I won't be able to manage a ventilator. Hey, I attended a 13-hour CPD program just to look at that. And you can see under your completed courses there, it says, Dr. Mawela, do you want your certificate? I can always say, yes, I want my certificate to be ready, and I will show you now, how my certificate is good. Yes, let me show you. So that you can understand it nicely. There's my certificate, my name, my MP number there, the CPD accreditation in 13 points. And also if people want to verify the certificate, they can just email us, at that point. So it's quite an intuitive platform, and I hope that you'll be able to enjoy it on the same portal where I was. Just to show you one more feature, which is very valuable, is that you are able to look at if you're on a waiting list for some of the programs, if you have made some orders, some of your e-learning programs, you can view, you can make payments, you can also change, cancel registrations, and so on. So do visit www.clinicalcareplatform.com and then explore some of the courses. We are working on generating more and more, content for you, and hopefully you start to get great value from this program. So tomorrow, just after 1, do log in and get your certificates and save it. If you are being audited, log in, download your certificates. If you are struggling, drop us an email and let us help you as needed. Thank you. Thank you very much, Dr. Segula. You may take it from here. Dr. Segula, are you there? We might have lost Dr. Segula. May I check if there's anyone who has a question that they would want to ask about the presentation? Anyone who has a question, you may raise your hand. Dr. Segula, are you back?
Yeah, my apologies, I've lost my signal.
No, it's fine. You may continue with the session. Thank you, Dr. Segula.
All right, thank you, Dr. Mawela. I don't know if you have told us how do we become part of this clinical care platform to be a member.
Yeah, for now it's open for all, and all you need to do is to visit the site and then register, and then explore some of the programs. Yeah, some of the issues we will then update you as we improve the platform. Thanks, Dr. Skule. Thanks.
All right, not a problem. Thank you so much for the platform once again. Back to Dr. John Masina. I still don't have any questions on the chat. If there are any questions, participants, please feel free to raise your hands. But just to, one of the few things that you have touched, and I think it's very key, is the issue on the review of clinical standard protocols. I think it's very important. You have mentioned that we need to have our own standard protocol, depending where you are, whether at primary health level, district, or tertiary. Situations may differ. You touch a bit on facility, infrastructure, and all those things. So those are things that come into play into also making these protocols. And emphasis on research. For those that have attended my webinars before, they know that I've always emphasized on research. You check how your patient present. They may present differently from where they are. Socioeconomic background plays a role. Urban versus rural area may play a role. So I think it's very key and important that you do research as well, so that we can be able to fight this disease. Patrick Makambana, you are noted. And also one of the other things that we have touched is the issue on screening of patients, especially when they come to our hospital facilities. I remember in our very recent COVID response meeting, we had a debate regarding whether screening of patients is still important or not, because some of them, they seem to have crammed these questions that you're going to ask them, and then they pass the screening. And then when you plan them for theater and surgeries, you do the COVID test, they turn out to be positive. So it's one of the things that we're embarking on, especially in the context of research, that we need to improve our screening tool very dearly. We'll take a question or a comment from Patrick Makambana before Dr. Masina give us a comment. You can shoot Patrick Makambana.
Yes, thank you. Thank you for allowing me to ask some questions. I really do appreciate the presentation. I'm a doctor here at Mafikeng Provincial Hospital, whereby I'm working in a COVID area. Really, it helps us a lot to emphasize for the things that we are doing and to do it more the way he stated. But we face some quite challenge, whereby, as you say, you have to escalate from nasal till we ended up to CPAP machine. But when we reach CPAP machine, to intubate a patient, it becomes quite a bit challenging, because to escalate to CPAP, sometimes some patient may desaturate to 20 desaturation. 20% of saturation. And when you put it on CPAP, you can raise maybe to 8 something. And later on, the patient can decrease to 20 on CPAP, which means to come out from CPAP to sedate the patient, to intubate the patient, it becomes quite challenging. I don't know, according to his experience, should we escalate to ventilator or first to start with CPAP and go later on ventilator? I don't know really if, but we realize patients that are going on ventilator, they are not making it most of the time with all the secretion that the patient that are creating in the lungs, difficulty on doing the suction. But on CPAP, even though it's quite difficult for the patient, even sometimes we have to come to restrain the patient, but the patient is still awake. He may sometimes fight, maybe to cough up, whereby some secretion maybe may stuck in the lungs. Those are the challenges that I'm facing. I don't know, according to his opinion, how we feel like we can go about that. Thank you for that.
Thank you, Dr. Patrick. We appreciate your question. Dr. Masina, I think you had the question. Please shoot.
Yeah, thank you so much, and thank you, Dr. Patrick. I mean, it's one of the things that we've seen over and over. Our mortality on ventilated patients is really high. I think we've relatively done well. It has come down to somewhere around 50-40% mortalities, or maybe it's a 50-50. But I think what is important is to understand the patient and also just see how well you escalate. How much pressures are you reaching? Sometimes we reach pressures of like 15 in terms of the pressure support, and something like 15 in terms of the PEEP, or the positive end expiratory pressure. So yeah, it's not a yes/no answer, unfortunately, and that's where the challenge is. But I think it's from patient to patient care. If you think, especially if the patient is confused, they cannot understand instructions, they are fighting, I think intubation will be a better method to go with. But remember, before you intubate them, you really need to pre-oxygenate them. So you can use NIV as a pre-oxygenation method, and once your sats have gone up to a reasonable amount, maybe 85, 90, if you can reach those ends, and then you can intubate a patient. The emergency physicians always say it's not the failure to put the tube down the throat that kills the patient. It's the failure to ventilate or oxygenate the patient that kills the patient. So remember, every time you want to intubate a guy with sats of 20, your pre-oxygenation should be very, very good before you intubate. Otherwise, if you intubate them with sats of 20, they are going to die. So yeah, unfortunately, it's not a single answer, yes or no. But just consider the patient, consider the situation, and also just consider where you are. Sometimes intubating at a low center, it's very, very difficult because this patient won't be accepted at a higher center, and you are not going to be able to nurse a ventilated patient at the center where you are. So a lot of consideration has to be put in: patient factors versus system factors versus geographical factors as well. So yeah, I hope that helps. Thank you. Over.
Thank you, Doctor. Thank you for the wonderful answering. Talking about patient versus system factor, one of the questions that were posed prior to the presentation was the use of oxygen at home by patients. You know, it was a question of its effectiveness and if there are any instructions provided to those patients, especially standard protocols from WHO.
Yes, we do have a standard protocol on home-based care, but I'm yet to find out the standard protocols when it comes to domiciliary oxygen. But what we've been doing as clinicians is that we've been using the same protocols, like the ones for post TB sequelae and also COPD domiciliary oxygen protocols, where we teach them how to use these oxygen concentrators. We teach them how to change the tubes. We teach them how to switch it on, switch it off, put it into electricity and everything. But the good part with COVID is that this is not permanent. It usually resolves as time goes by, maybe 2 weeks, 3 weeks, and the patient won't need any oxygen at all in terms of at rest. They might need this oxygen from time to time when they do some exercises. So at the moment, we don't have the standard protocols as specifically to home-based care oxygen therapy in COVID, but we are using the same post-TB and COPD standard domiciliary oxygen use. So we're kind of leaning, but I think it's one area that needs a lot of research, like you said, and a lot of guidelines as well. And remember, we are building the boat as we sail, and that's where the problem is really. But yeah, I think the guideline is that yes, there's a role of oxygen, especially post-COVID oxygen requirement. But the protocols are yet to be developed. So we are leaning on the other pathology standard operating procedures that are in place. Thank you. Over.
Thank you so much. The last one before we hand over back to the host and close the meeting. One of the issues that we've been lambasted with in most of our seminars or meetings, or even the Ministerial Advisory Committee, is the issue of us as clinicians to develop protocols on treatment of early COVID or early stages of COVID. What is your take on that?
Yes. So remember, in COVID, our biggest challenge is, are we treating too late, or when should we start the treatment? That has been the biggest question. Unfortunately, with COVID, we are not sure when to start the treatment. Is it at the time when you are infected, or is it at the time when you are all now showing signs? Because we know that actually by the time you start having your symptoms, the viral load is actually lower than the viral load from the start. So should we start steroids when the viral load is very high and stop the steroids when the viral load is low? But we know that inflammation and viral load are actually vice versa. The viral load will be very high at the initial stage of the infection as the inflammatory markers are building up. But with evidence, steroids are only indicated in moderate to severe disease. So, Doc, I have no straight answer for you. And it's difficult. We can't tell. We can't tell when to start and when to and really when to stop and what to do. But I think the best guideline that we have at the moment is that we use steroids in moderate to severe disease, and we use all the other medication like anticoagulation, oxygen therapy, only to target the symptomatic relief. We don't still have evidence for starting steroids and anticoagulation in early disease. So in early disease, it's basically monitoring non-pharmaceutical intervention to prevent spread of the infection, and monitoring for severe signs of disease. Then you start the treatment. Thank you.
Well, thank you. Sorry, I thought that would be the very least last one. What is your take on bronchoscope for clearing mucus plug and thick secretion that hampers effective oxygenation, especially what Dr. Patrick Mabakana from Mafikeng has been saying, that there are issues with the mucus plugs and secretions that come from ventilated patients, and also vis-a-vis the risk of healthcare workers if they do this procedure, especially in active COVID. What is your take?
Yes, so there was a ministerial advisory communication, which is also part of the COVID-19 case management team that looked at the evidence around bronchoscopy and suctioning in patients. And the recommendation was not to recommend the use of suctioning and bronchoscopy as a widespread modality for management of this secretion. Reason being that it did not show any benefit compared to other medical forms of bronchial clearing. And one other aspect that I think was really considered was the aspect of healthcare worker infection, because at that point you are at the highest risk of you getting infected. So, so the exposure to the patient, the exposure to the healthcare worker will be very, very high. And then the other issue that you need to consider is also the personnel. How many pulmonologists and how many bronchoscopes do we have that we should recommend the wide use of this modality for therapy? That was also another backstock when it comes to this management. But it has been recommended that in a tertiary hospital with a pulmonologist around with the right equipment and the right protection for the healthcare workers in terms of negative pressures in the room and all the PPEs that are involved, you can go and do it, but be on the lookout that it will be very difficult. There will be very few centers that will do it.